Good afternoon. Welcome to today's presentation, the Centers for Medicare and Medicaid Services Conditions of Participation Regarding Hospital Electronic Notifications. This is a presentation from our friends at KHIE, and today's speakers are Andrew Bledsoe and Brandy Janelle with KHIE, which is also known as the Kentucky Health Information Exchange. It's located within the Cabinet for Health and Family Services in Frankfort, Kentucky. My name is Catherine Shaw, and I'm with the Kentucky Regional Extension Center, and our short name is Kentucky REC. So the Kentucky REC and KHIE often partner together to help provider organizations in the state, small and large, use health information technology to improve patient care and quality while addressing federal and state regulatory requirements. Our main speaker today is Andrew Bledsoe, who serves as the state HIT coordinator and deputy executive director for the Office of Health Data and Analytics within the Cabinet for Health and Family Services. KHIE's primary focuses are promoting the statewide exchange of patient health information, spearheading new services designed to improve care coordination, and offering new avenues to reduce reporting burdens and foster interagency cooperation. These fulfill Andrew's goals throughout his 16 years in healthcare, improving healthcare delivery, especially in rural medicine, through leveraging health information technology to improve quality care delivery and outcomes for patients. Brandy Janelle, our co-presenter, serves as the program manager for KHIE and has been with them for over 8 years. She currently oversees the Promoting Interoperability and Direct Secure Messaging programs. Brandy leads the high-tech efforts at KHIE and is a resource for providers and others with questions regarding the program. Brandy understands the unique challenges faced by providers in Kentucky and is known for her problem-solving approach to her work. For today, you will be muted throughout the presentation, but if you have any questions, please enter them in the chat feature. We'll have time for Brandy and Andrew to answer them at the end of this presentation. Take it away, Andrew.
Okay, thank you, Catherine. I appreciate that. And I appreciate the REC always being so willing to partner with us and to help us put on these webinars, events, and help to promote some of the work that we're doing. So if we can go to the next screen, Brent. Okay, so many of you, I was looking through the name on the participants, and I know many of you are familiar with KHIE and the Kentucky Health Information Exchange, but I'd be remiss if I didn't take the opportunity to give a little bit of an overview for some of those on the call that may not be as familiar with us. The Kentucky Health Information Exchange is an HIE that is wholly owned and operated inside of state government here in Kentucky. We are the state designated HIE, and we do represent the entire geographic region of Kentucky. We are a unique HIE, and we are often noted and cited across the United States for our uniqueness because of our positioning in state government the way that we are. Most other HIEs, they are either nonprofit entities, maybe they're a public-private partnership or a for-profit HIE, but to be solely inside state government this way is fairly unique. It's actually of a great benefit to the healthcare organizations in Kentucky because it allows us to facilitate a lot of coordination and collaboration for multiple projects and initiatives. I actually just got off the phone and was almost late to this. That would be bad to be late to my own presentation, but talking about a unique use case in which we can potentially be collaborating with a new department inside the cabinet. So it's really neat because we're able to have a lot of those conversations, be very forward thinking with the technology that we have and with other technology projects in the cabinet and leverage that for the benefit of the Commonwealth. And so kind of specifically, some of the other agencies that we most notably work with, public health, we are designated as the Public Health Reporting Authority, which really just means that if you are communicating electronically and sending public health data electronically into DPH, that is facilitated through KHIE. And just simply that's because we're already working with around 4,000 facilities around the state of Kentucky, and it just made sense for there not to be duplicative efforts within different agencies. We're already talking to the hospitals, talking to the doctor's offices. So let's just kind of make that more of a holistic approach and capture and exchange that information. That allows DPH to do the projects and the functions of DPH that they want to do, and they're not having to build and set up technology programs themselves. And so you, I'm sure, recognize this from the work we do with the immunization registry. You've heard us talk over and over again about syndromic surveillance. We've done a ton of work with the COVID lab reporting, electronic case reporting, advanced directives, a lot of different things that we collaborate with public health on. Medicaid is a huge partner and another major benefit to the Commonwealth, because that's how we receive our funding to offset the operational expense of the HIE wholly. We take federal Medicaid dollars so that we do not have to charge for any of our services to you. And so I'm excited today to talk about a new service that we're launching that additionally the Medicaid dollars have funded that allow us to be able to provide a service for everyone. Community-based services, we have some really neat projects there that we're working on with their patient populations and making sure that appropriate data is flowing with the appropriate individuals and information sharing. I could talk about a lot of different projects, but we'll stay focused, we'll stay on task and talk through kind of what we're working on today. So if we can go to the next slide. I like to always start with this because this really explains the essence of our being, what we are seeking to do at a very basic level. Really, our goal is to facilitate exchange of health information. It's even in our name. And so this kind of shows how we do that. It shows a bidirectional flow of information in and out of the health information exchange. So kind of a couple different ways to think about this. You could be one of the organizations and you have a patient in front of you and you need to know information on that patient. You can ask the HIE for that information, and we reach out to all of the facilities and the participants who are connected to us. We collect that on your behalf, and then we send that back to you. And so you're able to have more, a deeper access to information from not just Kentucky, but from across the nation, from other federal pockets of information. It really increases the amount of data that you have as you are treating the patients. Now, kind of the flip side of that, in order to provide you a comprehensive amount of data, we have to have organizations contributing the data to us so that when you ask us for information on a patient, we have a significant amount of organizations who have given us that information or allow us to reach in and have access to that information so that it's comprehensive in what we can provide back. Also, we talked a little bit about that facilitation of public health reporting. So you send that to us and then we send that to the appropriate public health agency. So you only have to send it to one facility, that's KHIE. You're not having to send it to each individual registry or public health function. Again, saving your organization time and money. So that's kind of just that bidirectional, that flow of information and how we help to facilitate that. So this is kind of what we do. If we can go to the next slide, I want to talk a little more deeply. Actually, I love this. So as we're moving into what we do and what data we exchange, this is my favorite graphic. This actually demonstrates across the top information that is made available via claims data compared to information that is made available via EHR data. A lot of the times when I'm talking to individuals about kind of this information exchange, they immediately focus in on claims data. And quite frankly, that's because that's all they've been exposed to. I mean, healthcare has been built around claims. We've built payment processes, quality programs. I mean, it's quite incredible what we have done with the little amount of information that's available in claims. We connect to EHR systems and we capture the clinical data that's stored inside of the EHR. This gives us a much greater depth in the amount and the types of information that we have access to. And so instead of just that an encounter had been coded or performed, we can tell you what happened in that encounter. Instead of just a procedure had been coded and completed, we can tell you what were the results of the procedures, what were the complications of the procedures. We can tell you lab results, vital signs information, just a lot deeper information that we are able to provide. So I like to show this to kind of give a basis of that difference in claims versus clinical information. And actually the world that we exchange operates in both of those arenas. If we can go to the next slide. I do like to be very specific and intentional with the information that we exchange. Now, the purposes of this webinar, we'll get into in just, I think you only have to bear with me 2 more slides, but I want to kind of give a broad overview for the full range of the information that we exchange. First is the ADT. This gives us, stands for admission, discharge, transfer. This gives us vital information that at the basis of what we do establishes a unique patient inside of our master patient index. So this is how we identify that Andrew Bledsoe is truly the Andrew Bledsoe, and that there's not Andrew Bledsoe or Andy Bledsoe or A Bledsoe. Those are all combined into that one unique individual. In addition to establishing that patient, we get a lot of demographic information. So phone numbers, address, social securities, a lot of information that can be beneficial as you're looking to either contact or establish patients inside of your system. Additionally, we get details on where patients are seeking care. And this tells us if a patient has gone in or out of a facility, we can almost track patients' movements within the healthcare setting in Kentucky. Even building on top of that, there's a lot of clinical information that's available in there. So who was the provider treating the patient? What was the organization that the patient was treated in? We can even get as detailed as this patient was in room 203 on the 3rd floor of this hospital. So the ADTs is really a basis and at the core of what we are doing, and it's really foundational for the service that we'll be talking about in a few minutes. Lab results, so we do have connections with a significant amount of commercial labs in the state of Kentucky now, in addition to reference labs from all across the state, exchanging those lab test results. Radiology reports up until really October, November, that was only a read or transcribed findings and recommendations of an image. And so we actually launched into a new project. It was a $9 million project to launch an image exchange where we will be exchanging the actual images in a DICOM standard, so they're diagnostic, as well as making them available through a couple different portals so that anyone has access to those images. You may see a follow-up webinar on that. We have a lot more to talk through on that project as we go throughout 2021. Other transcribed notes is a catch-all. It's typically operative reports, emergency department reports, history and physicals, a lot of different types of information in there depending upon the organization contributing and the EHR system that that organization has. CCDs, summary of care records. We really get into a lot of the deeper information here, kind of specific to that encounter that had occurred either at a hospital or outpatient ambulatory facility. We do show Medicaid claims data, anything that is paid by Medicaid, both MCO and True Medicaid. We also show what's logged in the immunization registry, our syndromic surveillance program, and communicable diseases. So again, just kind of giving you a fair understanding of the types of data that we comprehensively exchange inside of the HIE. So this is those types of data. This is the amount of data that we exchange. Actually, this is probably a couple months old because we did shoot over, we've been onboarding feverishly for the immunization registry connections, and we are well over 2,200 connections there as we're trying to onboard as many facilities as possible for the COVID vaccine to be able to make sure that they are appropriately recording. You'll see the hospital column is obviously hospital. Other can be primary care providers, specialty providers, or some of our non-traditional contributors. We have chiropractors, dentists, optometrists, ophthalmologists contributing, as well as many behavioral health centers. All of the state and the community behavioral health centers around the state are contributing information. We have a fair amount of correctional facilities, both county and state, that are contributing information, and the EMS system as well. Won't walk through all of these numbers, but do like to point out that around 95% of the hospitals are submitting data to KHIE. Now, we work with 100% of the hospitals in the state, but that kind of variance is from hospitals who may be in flux with their EHR system and transitioning from one to another. Platinum at the bottom is the number of organizations who are exchanging CCDs. So I think if we go to the next slide, that gets us kind of through that basis of who we are, what we do. Now let's talk through what we're here to actually talk about today. I know 20 minutes into the conversation and we're finally making it. Now we're undergoing a bit of an identity crisis in trying to determine what we are going to call this. We've gone through several names, so we may start up a challenge where if we want to have a naming challenge and we'll accept submissions, but this is our event notifications that allow you to be compliant with your CMS conditions of participation for the rules that come from the patient access and interoperability rules. Now, we're loosely working with CHIE, but it's a work in progress. So I do want to delineate here that this is a difference from our KHIE event notifications. Our event notifications that we had developed as part of the new HIE deployment were provider driven, meaning that a provider or a healthcare organization tells us what patients that they want to track. And anytime that those patients move inside of our system, we tell that provider that that patient has been admitted or discharged or had an encounter. This CMS conditions of participation hospital electronic notification is more of a patient-driven notification. And this is that the patient is telling the healthcare organizations where they want their information to be sent. And per the conditions of participation, you are required to send their information to those providers. Now, we at KHIE, we receive ADTs from nearly every hospital in the state of Kentucky. And the basis of this event notification is inside of that ADT. So it makes sense that we would develop and provide a service kind of around that ADT to help you meet these conditions of participation. So if we can go to the next slide. And this is over my head, so I'm going to ask Brandy to tap in and take this slide.
Okay, thank you, Andrew. First of all, don't be afraid. I know this is a very wordy slide, but I'm not going to read it to you. As I'm sure most of you know, it's pretty difficult to jazz up a federal rule. What I'm going to do is I'm just going to review some of the key components of the measure, and the rest is just for informational or resource purposes. So to jump right in, at the very core of this measure, to put it simply, CMS is wanting hospitals to utilize technology to improve patient care and outcomes. I'm sure this is nothing new to this group. We've been working on this for the last several years. Basically, they want hospitals who collect patient information electronically to share that information with providers who have the capability to receive the patient information electronically. However, under this measure, in the final rule, CMS is only requiring hospitals, psychiatric hospitals, critical access hospitals, to send notifications that include the patient name, the treating practitioner, and the sending institution name. But they do make a point to encourage hospitals to send additional patient information as permitted by their state and federal laws. I do want you to also note that all of the post-acute care service providers and suppliers required to receive notifications are listed on this slide, but I want you to pay particular attention to the phrasing other practitioner or other practice group or entity identified by the patient as responsible for their care. So, for example, a patient can request that their cardiologist, their endocrinologist, or anyone else the patient feels is responsible for their care, they can request that they receive the electronic notification as well. And of course, this is where it just gets a little tricky. But the notification itself, it must be sent when the patient is registered in the emergency department or is admitted into inpatient care, and when the patient is either discharged or transferred. So the hospitals are going to be required to demonstrate that their system notification capability is fully operational by, I believe, May 1st. But thankfully, CMS is permitting hospitals to send the notifications directly or through an intermediary that facilitates the exchange of health information. And luckily, that's where KHIE comes in. And Andrew, I believe this is a perfect segue for you to jump in and continue the presentation.
We can be that intermediary for you.
Yes.
Okay, next slide, Brent. So let's talk through how this works. This is a data flow for how the system that we have developed and can provide to you operates. So I've kind of set it up into 3 steps that we'll talk through more specifically. You would be the sending facility. So there's a couple different healthcare facilities that are involved in this, but just keep in mind that the requirements are for hospitals, and you as a hospital would be the sending facility. So the patient presents to you and they're being admitted into the hospital or into the emergency department, and then it is your requirement at that point through the conditions of participation to capture that information, who they want their information to go to, and then send it to that individual. So that's step 1, capturing that patient's request that they want their information to go to provider X and sending that to KHIE. Step 2 is we take on the responsibility of finding that provider and sending them that notification. And then finally, we will tell you if we were successful in tracking down that provider and getting them that event notification, or if we were unsuccessful in being able to do that. If we can go to the next screen, I'm going to start into step number 1. So from the originating facility, from the UR here into KHIE. And so the types of ADTs that would be able to generate this notification would be a patient admit, discharge, transfer into the hospital, or the emergency admit and discharge. So for any one of those occurrences inside your system, you know, typically in normal functionality of just the healthcare, your EHR system is generating an ADT when any one of those events occurs and sending that to KHIE anyway. Nearly every hospital in the state of Kentucky is sending us ADTs. So you are already doing this, chances are. And so for the requirement that we're talking about, you need to map into that ADT some information that tells us who we need to track down for you. So required fields would be the name of the provider and the NPI of that recipient provider. So additional fields that you can build on top of that requirement is organization name and NPI of a recipient organization. Additionally, you can add in a direct secure address of the recipient. Now, when we started building this system, I reached out to a lot of hospitals to try to better understand how you may maintain provider organizations, provider directories inside of your system. And so I learned that overwhelmingly, nearly a lot of the hospitals have internally their own type of a provider directory that you can lean to capture this information. And so this responsibility would be on your organization to map into the ADT that provider name and that provider NPI at a minimum, so that then we have something to try to go out and track down that provider. Moving kind of into the more technical specifications, there are 2 different ways that you can map that information into the ADT. We can use the role field inside of the ADT segment, or we can use PV 1.52, which is listed as the other healthcare provider. We actually already see that a lot of organizations have primary care providers mapped into this field. So at least the name. And so again, there's some of you out there that are already doing this, and you may not know that you're doing this. But there's 2 different ways trying to meet different capabilities for different hospitals and what you are able to, how you're able to manipulate and work with that HL7. So again, the requirements for your organization are to map into that ADT this information in either one of these two fields. Now, additionally, I say that required is name and NPI of the recipient, but the rule actually states that treating practitioner is required as well. It's not so much required in the message that comes to us that we have to have it to facilitate this process. It's just a requirement of the rule. So you would also need to map that into the HL7 message as well. So again, step one, sending the information from your originating facility into the HIE. This is the process that would be followed. Go to the next slide. Step two. So we take the ADT that you send to us, and it's our responsibility to deliver that to the individual that you have designated. We have multiple options to be able to do that. And so first on the list, it's almost like a decision tree or a triage. We look to see if that provider or organization has event notification integration service with KHIE. This is a service that we provide wherein we can send event notifications directly into an EHR system. So that's kind of the first thing. We recognize that the more that we can provide this information into an intuitive workflow, that it's going to be better for the receiving organization because we're not requiring extra steps or extra burden for them to go outside of their workflow to receive this information. So first, we want to send that via the integration mechanism. Now, for us to do that, we do require the organization NPI to be mapped into the ADT. So in cases where you would have the organization information, if that can be included, that's just going to allow for a better receiving mechanism on the other side of this. But again, not a requirement. It's just if that organization NPI is not included, we step down to the next level. We're also developing and we'll be launching in a few months a full HL7 ADT delivery. So right now we deliver event notifications through the FHIR API. This will allow us to send a full ADT across that HL7 interface. And it's another delivery mechanism for event notifications, so to speak. But it's also, we're leveraging that technology to send this CMS CoP electronic notification as well. This one also requires the organization NPI. But that's okay. If you do not map an organization's NPI into that HL7, we'll go down to the next step. If the provider that you have sent to us has an ePartner Viewer account, we will send that. The ePartner Viewer is our KHIE web-based portal where individuals can log in and find patient-specific information for individual patients. We do deliver event notifications and normal workflows into that platform. So we have duplicated that service to provide these CMS electronic notifications as well. So we identify that provider, we check to see if he's a ePartner Viewer user, and we'll send that directly into their ePartner Viewer dashboard. And then the next step, if they are not an ePartner Viewer user, we're going to leverage direct secure messaging to send the information. Inside of the direct secure messaging, we have 4 different ways that we're going to try to find that provider. First, we're going to look inside the HL7 message to see if you've mapped into the HL7 that provider's direct address. If you have, that's what we'll use because we feel that that is the most reliable source of truth that you have validated from your organization's perspective that that is a current direct address. If it's not mapped into the HL7 message, we will leverage the National Direct Trust Directory. This has actually long been an initiative to kind of develop a national phone book of sorts for direct addresses, but is really being propelled forward with this new conditions of participation. If we are not able to find that provider in the national directory, we're going to look in our Kentucky Medicaid provider directory. There are other provisions of these interoperability and patient access rule that requires Kentucky Medicaid to develop a provider directory, and they are including direct secure messaging as an optional field inside of that directory. So we will reference that directory as well. Now, as kind of a sidebar conversation, they will be developing an API. So if your organization wants to do an API to their API or a query, you can reference that for your provider directory internal to your organization as well. So if we're unsuccessful to find the provider in the Medicaid directory, we're going to use our KHIE provider directory. This is the one that has been longstanding within KHIE and has over 4,000 direct secure messaging addresses in there as well. And so this is kind of the steps that we will use as we try to track down that provider that the patient wants their information to be shared with. We can go to the next screen. Thank you. Okay, so step 3, the third part of this process is we need to tell you if we were successful in tracking down that patient. So we will provide monthly status reports that list, actually there's 2 different reports. There's an undelivered notifications report and a delivered notifications report. Now, based on our understanding and interpretation of the rules, we feel that we have given full faith and effort to try to track down that provider using 7 different mechanisms. And that's why we're comfortable providing this to you as a service, because we have done everything reasonably possible to track down that provider. But we need to make sure that you know which was successful and which was unsuccessful in being received. Now, we are only telling you that we found the provider and sent them the notification. We are not telling you that the provider has actually looked at the notification. There are no requirements in this to ensure that providers have reviewed the reports, and there is currently no threshold for that success versus unsuccess to be able to meet. But at this point, we will tell you what was undelivered so you could determine if you needed to do some manual steps on your side to try to additionally ensure that delivery. Okay, so that's the 3 steps that make up this event CMS conditions of participation electronic notification process. Let's talk about implementation status. So we have been working closely with our HIE vendor and CMS throughout actually 2020 calendar year to get this in place. We have received approval from CMS. We have received funding from CMS. So we are moving forward with the implementation of this. Our service will be available March 30th in the production environment, meaning that it will be live and we can be exchanging these notifications in a production environment at that time. Now, I know that that is pushing closely to that May 1st deadline, which is what the compliance date for the CMS conditions of participation. However, there is work that can begin now. So because we have determined which fields need to be mapped to, and we know what information needs to be mapped, you can take that back to your organization and begin doing that mapping. We can even be doing some preliminary testing and review of those ADTs to tell you if it would meet compliance. It's just that in a live environment, those would not be transmitted and received by the receiving party until after the March 30th production date. So I started the conversation of why KHIE, why are we doing this? Why are we providing this as a service? There were multiple reasons why we would want to do this and how we can add value to your organization with the service. First is a low initial investment. And I make that claim for a low investment because nearly every hospital is already sending us an ADT. That is a huge component to this service, in that if we didn't have an ADT exchange in place, we would have to start from scratch and develop that ADT, that connection, that HL7 connection, the ADT validation. So you guys have already knocked through several of the initial steps, and we're already well on our way to being compliant with utilizing this service. Reduced burden. So by using us as your intermediary, as Brandy says, this negates your hospital having to develop your own internal point-to-point connections or trying to manage this process of sending this information on your own. It's entirely possible using direct secure messaging. If your organization wanted to do that, you could be facilitating that on your own. But again, by working with us, you allow us the opportunity. We actually take on that burden of tracking down that provider and that receiving provider in place of you having to facilitate that process. Compliance, because we are supporting 7 different steps for delivery. We do feel that we meet the compliance specifications for this conditions of participation. So you can easily be compliant with that condition of participation. And then assurance that by us having multiple steps that we are doing everything that we can to make sure that we are delivering to the individual that should be receiving that notification. Next slide. Okay, so that actually wraps up. This is not a lengthy or burdensome webinar. It's actually, dare I even say, simpler service that we have developed. But that's kind of the core of what we're doing. Now, I know that there will be questions around who's already sending, what we're looking at, so we can get into more of those specifics on more of a one-on-one basis. But this is really our entry that we wanted to announce the service that we are providing and that we have been developed and how we can help the hospitals to meet these conditions of participation. I would be remiss though if I did not take the opportunity to walk you through a few of our other services. We won't go into details, so this is the last slide, I promise you, before we get to the question slide. But I do want to, at a high level, look at each one of these services that we offer. Now, again, these are not specific to this conditions of participation. These are just KHIE services that we offer. ePartner Viewer, you heard me reference that earlier. That is our web-based portal where you can query for patient information on an individual basis. It is also a dashboard for event notifications and for direct secure messaging for messaging out CCDs or clinical information, but as well as a single sign-on for getting to our Caroline portal if you need a standalone portal for direct secure messaging. And so we have worked diligently to make this a fast system with as much information and as much relevant information to be presented as quickly as possible. Platinum is our CCD exchange, and this is how we are exporting CCDs from inside of EHR systems, but also how we are importing CCDs directly into an EHR system. So this is really where we're truly meeting workflow procedures and that we are delivering our KHIE information into the EHR system, negating having to use multiple platforms. It is a little more cumbersome to do because it requires much deeper integration and data mapping. So there's more work. There is also can be considerable costs from your EHR system. Again, keeping in mind that we do not charge for any of our services. We will also be leveraging these Platinum connections to exchange the images and connecting to the PACS systems as well. Casper, we provide Casper reports through a couple different outlets. We deliver them to the ePartner Viewer. We will provide the Casper reports through a Platinum connection, and we are doing some direct integration working with the OIG on some NCPDP connections as well. Event notifications. So we spent a lot of time talking about the CMS conditions of participation electronic notifications. Event notifications are the provider-driven event notifications where if you are a provider and you want to track patients and be notified when they have certain occurrences, you would use our event notification system, and we can tell you that directly inside of your EHR. We can send it into the ePartner Viewer, or we can send it via direct secure messaging as well. We talked about Medicaid claims as one of the information sources that feeds into the HIE. A lot of different use cases there and a lot of information to be able to sift through. Direct secure messaging, we have a couple levels of direct secure messaging. We offer the standalone Caroline portal to send and receive direct secure messages. We do offer XDR connections that can send and receive direct secure messages in and out of your EHR system. And we do manage a provider directory of direct secure messages with over 4,000 accounts having been logged. Last is our patient alert query. This is another new service that we started providing last year. This is a simple electronic query that you set up from your EHR system to KHIE. And it's basically, I have Andrew Bledsoe in front of me. What do you know about Andrew Bledsoe? We currently provide back COVID status. So we can tell you if they have a current diagnosis of COVID, if they have previously tested positive for COVID, or if they are unknown for their COVID status. We can tell you if they are if they have a positive XDRO diagnosis logged in our system, that can be important because you may want to use specific precautions when working with that patient. We're also implementing an NAS query, wherein if a patient has an NAS diagnosis, neonatal abstinence syndrome, we can tell you immediately that they are an NAS patient. We are also have an Office for Children with Special Healthcare Needs query. And so we would tell you if that patient that is in front of you is what we call OCEAN individual who are receiving benefits from that program. And so we are continuing to build upon different use cases for this type of a query. It's a very simple to set up query and can be a lot of flexibility on your side, depending upon your EHR and how you can send and receive that information. But it is all driven from inside of your EHR system, again, allowing us to send that information back directly into your EHR. With that, if you have any questions, I would urge you to reach out to, more generally, more broadly about KHIE, maybe how your organization's currently engaged with KHIE. If any of the services that I've talked about today piques your interest, or if you just want to have good conversation, I urge you to reach out to these 4 individuals. If you walk away with nothing else, I can guarantee that you will have had a fun and lively conversation with them. But then they can also help with the onboarding process to KHIE and really are that first point of contact with us. With that, I think we move into the question slide. I have listed my contact information on here as well as Brandy's. We are both working very closely with this specific service line. So if you have very specific questions, please feel free to reach out to either one of us, and we will make sure that if we can't answer it, we find the right person that can answer your questions. But before we leave it to that, I think Catherine's going to help facilitate some questions.
All right. Thank you so much, Andrew and Brandy. And we do have a number of questions, so I'll just start at the top. Does the patient have a right to indicate they do not want anyone to receive their information? Either they don't have a primary care or they don't want their primary to receive this notification.
This is patient driven. So if the patients do not want a provider to receive that, they can elect to not have a provider receive that, listing no provider or choosing what provider that they would want to receive it. That's a great question.
Okay, great. Thank you. The next question is, will these reports show the method used to transmit?
It does not. It only shows that it was successful or unsuccessful. It doesn't necessarily, I mean, I feel like, and please tell me if I'm wrong, but it doesn't necessarily matter how we got it to them. It's just, at least for the conditions of participation requirements, what your focus is was it successful or not successful? That's where it will just be, the name of the individual will be listed on that report. So on the successful report or unsuccessful.
Okay, thank you. All right, and the next is a bit of a twofold question because it can come in a few different ways. What are the next steps for hospitals if they're already sending ADTs to KHIE or if they need to start from scratch?
Great question. So if you're already sending an ADT, your next step is to work on getting mapped into those 2 HL7 fields that I told you, the provider information. So at the minimum, we need the provider name and the provider NPI. And then you can build on that with giving us a direct secure message address or the organization name and the organization NPI. That's what we will need. Now, I would also say there's probably steps on your side to looking at how are you going to capture this. So during your admission processes, how will this question be asked by your admitting teams? Where will this information be inside of your EHR system? We often get a lot of questions around, can we map to the already established primary care provider? And so there are some steps inside of the EHR that you will be responsible to do to collect this information. And then second, getting that mapped into the HL7. I would urge you, if you are starting to do that, if you're starting to work on getting those fields mapped, reach out to us. We will coordinate you with one of our onboarding analysts, And so they can help you with that process, and we can be validating some of that from the front and help from the beginning as opposed to trying to catch up on the backside. So if you're already sending ADTs, those are the steps that you would want to follow. If you're not, we want to get you working with an outreach coordinator immediately so that we can capture your intent to send us ADTs. And then we will get you with an onboarding analyst, set up an HL7 connection, go through the connectivity process, and then we will include in our ADT validation these CMS components. So it's all kind of encapsulated into one. And if you're not sure if your organization is currently live sending an ADT, we can do that on a individual basis, not on the webinar, but you can either reach out to your outreach coordinator and they can let you know that, or Brandy and myself, and we can connect you with the outreach coordinator.
Okay, great. Thank you. All right. Another question is, does KHIE meet all of the CMS requirements to assist hospitals in meeting the conditions of participation for the hospital electronic notification measure?
We feel that we do, from specific to this ADT component of the conditions of participation. Again, because we have a long list of steps that we're going to take to attempt to deliver this information on your behalf, we have given that full faith and effort in delivery. Now, there is going to be some interpretation left on your side for that success versus unsuccess. I think the rule right now is just stating that you have the capability and that you are performing this. There are no metrics for the number of successful messages sent versus unsuccessful. And so we would leave, kind of that determination up to you as to, if you're seeing unsuccessfuls, do you want to follow up? Do you not want to follow up? But again, per CMS right now, there are no requirements that you have to have like a 60% threshold of successful notifications sent.
Okay, great. Next question is, when are hospitals required to have their electronic notification solution in place?
May 1st.
All right, that's a simple question. Simple answer. All right, and then are hospitals required to send electronic notifications to providers requested by the patient?
Yes. Yes, it does not have to be, it's not specific to a primary care provider. It is actually at the request of the patient. So if they want it to go to their specialist, their cardiologist or something, if they tell you that they want it to go to that provider, you're responsible for delivering it to that provider.
Okay. And then another question is, how will KHIE ensure the electronic notification reaches the intended provider or providers?
So that is a good question. And this is kind of where I'd stated that we're not validating that the provider has read the email. If it is the responsibility of providers to provide, to have made available their direct secure message address. So if it's going to be direct secure messaging, we have to lean to the provider's responsibility in keeping that up to date, whether that be with the national directory, with our Medicaid directory, or with our KHIE directory. Now, we do try to stay as up to date with that as possible. So if we are notified that a provider's direct secure address is no longer valid, so we will receive, our system will receive that notification back, and then that would be listed as a patient that was unsuccessful on your roster. We're also working continually to keep clean our provider directory. And so we're continually pushing out notices to organizations to let us know if you have updates to the provider directory. And so we're trying to keep that as clean as possible. That is not a specific of this condition of participation, but it is something that we do try to work to keep clean. And there are some technical capabilities in there, at least, that tell us if a direct secure message has been closed or turned off, that allows us to keep that clean somewhat. But there is certainly the opportunity there that it would never be perfect.
Okay, great. Another question is, do we need an addendum sign to show we are sending this information through the ADT feed?
Right now, we do not have an addendum. We have elected not to do an addendum for this service because it is pointed, the type of information that you're giving us is an ADT, which is outlined in an addendum. So the only addendum you would have to sign would be that ADT addendum. We don't have anything specific. Now, if you are thinking about your records for the conditional participation, we would be glad to develop like a certification letter, or some type of a notice that you are using our service. We would be happy to do that.
All right, and I have another question. This says, it's a little off topic, but I need guidance on penalties for not having EPCS.
EPCS. I'm not offhanded familiar with that acronym. If someone wants to.
Okay, well, we could revisit that person after the webinar, later on. So
Is Becky Blevins. I think Becky's trying to stump me. That's what she's trying to do.
electronic prescribing controlled substances.
Electronic prescribing controlled substances. I'm going to have to think about that one a little bit
All right,
more.
so yeah, we'll revisit that with the folks who are talking about it individually. And I think that is all the questions that have been submitted for today.
I do have one in my direct message. Is there an
Oh.
advantage to using the API FHIR method versus the direct message method? Again, from your perspective, that's really not going to matter to you because you're going to send us the ADT over your HL7, and we identify FHIR as a delivery method versus direct. I feel like it's better. So if you can give us the organization name and MPI, it's better for the receiving provider because at that point we can send the notification directly into their EHR system. Direct secure messages, a lot of the times those are also in your EHR system. So it's really just kind of depends, but that I think the FHIR, the API method is probably better just because it's going to go into more of like a tracker board place or more of an alerts place. It's kind of maybe a more attention getting thing. It just depends, honestly.
Great,
Hi,
I think
Andrew.
that's all the questions.
Can I add one thing to that? Well, actually, the previous question. Of course, KHIE will always give a letter of support, but basically CMS is just really going to look at your workflows and just make sure that you have the steps in place to send these notifications and that your technology can do it as well.
Becky, I got a note here. Becky was actually helping to answer the EPCS question.
Oh.
So, and her statement is there is a waiver that can be signed per provider if they are not able to do EPCS. This allows additional time to get this set up. So thank you, Becky. I would really, I would be glad to hear feedback from everyone on a couple different things. If you have thoughts on different, we hear a lot of differing interpretation thoughts and questions on interpretation of the rule, about our service and how we've set it up. If you have any thoughts on that, I'm just really curious. This is a brand new service for us. We did a lot of research up front with organizations to try to make sure that it was something that was easy to engage with us for. So we really were intentional about not building this in a silo and working with facilities. So if anybody has any just thoughts, questions, or even on the presentation, if I was not clear about something, or there's something we need to talk about better, or if my jokes are lame, please feel free to let me know.
Andrew, we have a last minute question that just came in. How will patients know they can request their records be sent to multiple providers?
It is, that's a good question. I don't know that there are any requirements for providers to market it to patients. They're to my knowledge, they're not required to tell patients that this is a thing that they're supposed to do. It's probably something that's going to be slow to be adopted by patients, but may gain some traction as people start to see benefits or value. But to my knowledge, that, other than monitoring federal legislation and regulation, that there is really not too much telling patients that this is, at least requiring that patients are being told that this is something that is now an option mandated that is available to them.
Yeah, and you can always include that in patient education as well, just in your individual hospitals.
Questions, and we're almost at the end of our hour also. So I would like to say thank you so much for everyone joining us. And if you have more questions, you can contact KHIE or the Regional Extension Center, and we'll pass those on to Andrew and Brandy and the team at KHIE. And we really appreciate your taking your time out of your day to join us today, and especially right after the holidays and getting into the new year. I know there's a lot on your plates, and we really appreciate you joining us today for this important information.
Yes, I agree. Thank you. Thank you, everyone. And thank you to Catherine and Mindy and Brent and the REC for helping us to facilitate this. Always appreciate the partnership.
Thank you so much. And we really like working with you, and I hope everyone has a good day.
Yes, thank you, everyone.
Everyone.